Xavier, thank you for coming to the BTS
No problem,
conference.
pleasure.
What's your thoughts of the meeting so far and the collaboration with the STN at this meeting?
So I've really enjoyed the talks that I've listened to. The Scottish Trauma Network talk this morning I thought was really inspiring. Both the speakers, both Tims, I think did a great job. Really centred it back to what we're in the business for. Focused on patients, equity, and the challenges that they have. I thought were fascinating.
And the way they've overcome them is...
Yeah, and it just goes to show that trying to fashion a one-size-fits-all solution in such a complex environment is really tough. Being flexible and saying, well, we're going to do it this way in this part of Scotland, this way in a different part of Scotland, giving people the freedom to say, look, no, this is how we should do it here.
And coming in last has some advantages, right?
Yeah, for sure.
Because you watch all the mistakes beforehand.
That's right. I mean, and they were sort of slightly apologising, in a sense. They're saying, oh, well, you made the mistakes and we're learning from them. But that's exactly right. I mean, that's what they should be doing.
Absolutely, because ultimately our
We're
healthcare
all
systems
supposed
are
to
very
learn.
similar.
Exactly. Learn from each other.
Perfect. And currently, technology and data is key in trauma. It's key to us standardising and measuring services against each other. But actually, where do you think we are at what we're measuring well now, and where do you see the future of this space? Data and tech that will help us.
Yeah, that's a big question. Okay, so I think that the major advance that we can make as a system is the utilization of the data that we already collect, rather than focusing on collecting minimal additional items. There are perhaps one or two items which are exquisitely important that you might choose to collect, key amongst them being patient-reported outcomes or experiences, because it's very difficult to source those from routine places. But as we heard with the federated data platform, the FDP, and other approaches of aggregating data, most of the data that we want are already being collected. The problem is that we don't have systems to aggregate them, and we don't have capable systems to safely and properly safeguard the legal requirements in order to then process those data. I think the system is alive to that, and the government is alive to that, and we're making big strides towards it. But of course, everything's frustratingly slow. It takes years when we want it to happen in weeks. So I think that's what we can do within the system. I don't really know, but you kind of watch from the sidelines about AI and what that might bring. I'm no expert in that space, but if we're able to aggregate the data so that you can deploy those tools against it, I think that's a potentially limitless treasure chest of improving outcomes. So you can imagine bringing together routinely DICOM data alongside clinical data, alongside genomic data, all of these multimodal systems. And if we were able to aggregate it for those people that can deploy the tools and train and then use those tools, then I think we could really accelerate things.
Completely agree. I mean, I gave a talk at the BOA actually on this a couple of years ago about harnessing machine learning. So it's not true intelligence. It's actually just, it's still on train tracks. It's following a path that we predetermined for it to some extent. It's now starting to and flex a little bit and run at its own speed occasionally, but it's not quite AI yet. But I think exactly what you said, you've got to connect all those data points. And ultimately, when we look at data on patients, polytrauma patients, by the time they leave hospital, there's probably hundreds of thousands of data points, all of their bloods, all of their OBS, all their heart rate, everything that's happened to them in that entire system, their ventilatory parameters, everything, none of which we analyse at the moment. You feed that into a machine that will start to pick out trends and associations that we probably never even thought of, and that's one of the huge potentials of AI, is that it has the capability to look at hundreds or millions of data points and actually try to find something that we may not have thought about, that somebody's serum rhubarb on day 1 is actually linked to a heart rate variability at day 3, which then predicts a poor outcome on day 7.
If you look at resuscitation fluids and the move towards blood products in resuscitation, and then a number of trials that have been conducted recently where we had hoped and had fully anticipated oh, well, of course, we're going to give X blood product and everyone's going to do much better. And what did it show? They didn't do better. And if you look at the historical literature in cancer, particularly now emerging literature in rheumatoid disease, if you take an intervention, a single intervention, and you deploy it at a population level, it frequently fails.
Yeah, absolutely.
There is a subgroup of people who respond.
Yes.
And the idea that something as complex as the clotting cascade and inflammation in the body is not got genetic predispositions to response and non-responders
Absolutely.
is madness.
Absolutely.
So I'm sure that stuff will yield a result, but we need to aggregate and we need permissions to collect information. Because everyone that has a blood sample, you have their genome, right? You have their circulating plasma, you have all their circulating proteins, so you've got their expression profile as well.
Yeah, absolutely.
But we're not using it at the moment.
Absolutely, absolutely. So you're one of the preeminent researchers in orthopedics in this space in the UK. Are we nearing the death of the RCT?
No, I don't think so. So I think the RCT is still the best tool that we have to differentiate marginal gains. But it is not the be-all and end-all, and it sits within an architecture of research, some of which is, like I presented, that was not a randomized controlled trial, but that was alternative ways of using routine data in pseudo-experimental designs. And frankly, I mean, I was a little bit irritated, sort of in my heart of heart, when we rolled out regional trauma networks. So why are we not doing a step wedge randomized controlled trial? But the complexity around doing that and the political drive to do something fast is such that you will never do it. So
and you'd have hundreds of steps, wouldn't you? And
yeah, or even if you just have one per regional trauma network, everyone wants to get going, and it would have been impossible to deliver. So I think we do need different types of approaches. I think the space that RCTs will occupy will probably get smaller across that spectrum. But we will pick our RCTs more carefully in a space where we already understand the data quite well with non-randomized designs. So, for example, trial emulation is becoming very powerful and popular, and it's very highly predictive. So there was a lovely study came out of Harvard recently that showed that of 96 trials taken from New England Journal, JAMA, and other sort of big impact papers, they can emulate those. So they can reproduce the results without randomizing. But there will be a space where there's really, marginal gains being made, and it might be worth investing the time and effort it takes to do a trial. But doing a trial of, every intervention, which people kind of watch,
too long.
Yeah, people might have watched over the last 10 years and thought, where is this going? I don't think that will continue to happen.
Yeah. Okay. Yeah, that's my reading of the space as well. But what's your any experience with the trauma app?
No personal experience, no. Familiar with the app itself and also kind of sister applications, whether they be apps or based on web tools about collecting those sorts of data. Yeah.
Prospective data collection to me is probably the game changer that we need at frontline care, because I remember being a registrar auditing data or an SHO and trying to look back through records and work out why somebody had this and when they had it, and I remember once doing an audit for Peter Oakley on chest drains and trying to work out when the chest drain went in and actually trying to use a chest x-ray as a surrogate predictor of when it went in, and that you're finding obviously the x-rays were sometimes done 1 hour, 2 hours, 3 hours, 5 hours later, as you had no idea when it actually went in. And so who made the decision? And could you get away without one? Could you get away with one, etc.? And we were looking at missed injuries and thoracic injury at a time when CTs were being still embargoed. Like they used to do neck, chest, pelvic films.
Yes.
We're showing our age now.
Yeah.
But we used to get that, and we were pushing for a full CT, and radiologists were still going, you don't need that. You get an X-ray.
Yeah.
If there's something on the X-ray, I might scan it. And I think prospective data collection at point of care and having a way of tracking that live, and then obviously that feeding in. My understanding of the trauma app, that now feeds into the EPR, so you don't have to have someone typing in NMTR data the next day or 24 hours later. It's just being fed through. So it's sort of matched cohort data, and 90% of it, Rob was telling me, who's partly been involved, Rob Bentley's been involved in the design of it, he said 90% of it will be automated. So your NMTR data, 90% automated, will be important admin saving.
Absolutely. So I think, I wish people would stop doing the kind of research that you just described and would be incentivized to deliver, because it takes a lot of effort to get that kind of capability up and running in your hospital. Even if it's available, just deploying it in your hospital takes effort. Now, if we could incentivize people through our recognition processes that said actually doing that is more valuable than going and looking at a bunch of proxy outcomes on a chest x-ray, which doesn't move anyone forwards.
Absolutely.
So I think we can influence that. So we should try and do that. The second thing is integration of our tools so they work together. Is got to be something that we really focus on doing. So
Absolutely.
making our app where we're capturing data talk to our electronic health record. I mean, it's only within the last 18 months, I think, that two of the big hospitals I worked in recently integrate their data coming out of their anesthetic machine with their electronic health record.
Yeah.
I mean, what a data-rich resource.
Doesn't do it.
and is how crazy is that?
Yeah,
and you think this thing works inside the hospital, but I can't make it feed the electronic health record. So integrating the platforms so that they talk together. And Rob's talking around the National Major Trauma Registry about hoovering up data to reduce the burden, I think is exactly the right approach. And across the program in orthopedic trauma, we're doing exactly the same things. So we've skinnied down the data set as low as possible. We have 4 data items which you can put in a structured operation note that goes into your electronic record, and then you never have to talk to the orthopedic trauma registry. It all just happens every 24 hours. It uploads.
Your career in orthopedic trauma over 20 odd years.
20 years? Come on.
I mean, mine's 20 years. Come on. Mine's 20 years. Yeah.
Maybe 20 years, maybe. We'll see. Let's not split years between us. It's been a while.
What's the most important change you think you've seen in your career?
I think it's multidisciplinary working and the acceptance that is the way that we should do it. I mean, I think when we started, an orthopedic surgeon would just manage an injury by themselves. They wouldn't talk to their colleagues. They would come on their own call, they'd do the operation, they'd follow them up, they'd deal with the complication as and when it happened. And I can't remember ever seeing a joint consultant procedure, even between 2 disciplines. Whereas now I go to work and it happens all the time.
Yeah, it's very routine.
It's just normal.
Yeah, absolutely. Better for the patient, better for the surgeons.
Yeah, much better. Yeah.
Brilliant. Thank you. There's been a lot of shenanigans in the medical workforce over the last few years. Is medicine still a worthwhile career? And if so, why?
Yeah, absolutely. I mean, I still enjoy my day-to-day work. I mean, I've enjoyed my career, but I still enjoy going into work now. I recognise I'm at a different place to many of the people who have complaints that they're making, and I've got a lot of sympathy with some of those complaints. It is a different workplace to when we were running around out of university. That's not to say that I don't recognise their concerns, but I still think that the job that I do is enormously rewarding. And so I would always, if someone said to me, should I become a doctor? I say, yeah, but you've got to be a surgeon.
So, saving them from everything else.
Yeah, no, I mean, I still really enjoy it. I mean, I have a particular work, which so I spend a good deal of my time in the hospital, but I do have time out of the hospital, and maybe that is something that's kept it fresh for me. I am not a full-time NHS consultant by any means. Half my time is spent in the university. So that gives me a release. It gives me another set of challenges. It's different. And the challenges that we all experience in the NHS, I do get a bit of a break from that. So I realise that I am in a very fortunate position in that sense.
And your kids wanting to go into medicine?
No, but I mean, my kids are too young, so there's 4 and 9. But one of my nieces qualified last year. So there are still members of the youngsters. Yeah, I think they, before she went, no, she was committed for a long time to doing it. Okay. I think, but the reality is you just have to look at the demographic of the workforce in terms of where, the flow through. And we are hemorrhaging doctors, as my understanding, outside of the UK, which we can ill afford. One, because they're very expensive to train. So training them and then losing them is clearly crazy. But also we need them. So we need to look into our system globally across the NHS and say, what is it that we have done to disincentivize these people? Because they're clearly capable, because they're going and getting jobs elsewhere. Yeah. And the majority are working in medicine, just choosing not to do it in the UK. So I think the problem is real. But I don't think it's necessarily a problem with medicine per se. It's probably a problem with the workplace that we have now in the NHS.
Thank you. If you were speaking to 18-year-old Xavier Griffin, what advice would you give him? Would you do anything different?
Well, no, I've been very happy with the choices I've made. What would I tell my younger self that's different from when I look back? Now I sort of have to jump into that set of shoes. What would I tell them going forwards? I think I would say, look, there's a lot of uncertainty in life. And this is what I see amongst the trainees now. And hoping that you will be able to remove all uncertainty. And there are peaks and troughs of uncertainty. So you get onto your training program, that's a big chunk of certainty because you're very likely to progress. And then you get to you get to the end of it, and then there's a big spike of uncertainty. And life continues like that, I'm afraid. And it's just like that.
Get comfortable with the uncertainty.
Yeah, and it's okay.
Yeah.
It's okay not to know what's happening in a year's time.
Yeah, absolutely. How to cope with anxiety of uncertainty.
Yeah, and different people are going to cope with it in different ways. And I understand different people have different sets of challenges, and so that affects them differently. But I think it's really unlikely that you'll be able to remove it entirely from your life. And so given that, you've got to work out a way of dealing with it because it's not going away.
Absolutely. Thank you.